we get the same kind of misalignment sometimes. I need to get back to work. You don't understand the burdens in real life I have to support my economic survival. No, it's too early. You have to do X, Y, Z. And I think that's so vital that we figure out how to move towards alignment rather than fighting with patients about these kinds of goals, and how that becomes a focus of improving things. John, I think you had your hand up.
I think John's hand might be residual. John, did you put it up again?
Oh, I didn't. I think Rob.
I think Robert might be next. Yeah, absolutely.
Or maybe Rob had his residual hand up too. I don't know. I think
Rob is active.
Hey, I'm happy to comment, but I want to give others a chance. I know Corey had her hand up now as well.
Yeah, and so I want to echo in so many ways, because given my work is primarily within peer recovery support services, essentially everything Ashley said, right? And I think, as we thought of interdisciplinary teams between clinical, medical, and community-based recovery support services, I think in large part, as we've integrated peers, there's certainly been some bilateral learning, but I think this is the opportunity where real bilateral learning can occur, because we do have a model that works in goal setting, recovery planning, if you use that term, RAP planning on the mental health side, that puts the person in the driver's seat, right? And I think Michael, the way you had framed the question, right, of what goals should we set for patients or in recoveries, we shouldn't set any goals for them, right? We should provide options. They should tell us their goals. And I think that changes dynamically over time. But I think we consistently do see that in clinical care, and to a lesser extent, but still present in medical care, where we have this idea that we have goals, whether it's based on a remission and diagnostic framework or something else. But the one thing that community-based peer services do really well is the idea that they're an expert in anything except for their own process. And how can I help you today? What do you need? What are your goals today that may change tomorrow, but often aren't about substance use or mental health concerns? They're, if we take a Maslow's hierarchy of needs framework, they're about housing. How am I going to feed myself? Can I pay my bills? The substance use is the last thing. Whether you call it self-medication or not, it's something that occurs, but it's not the thing. In an RCO framework, very frequently, unless they're coming to 12-step groups embedded within those or smart recovery that are abstinence-based, that's the last thing they ever express today. They made 6 months down the road or 12 months, 2 years. That's what they get to choose, but their goal setting should be driven by the individual, whether it's in a clinical framework or a community-based framework. But I think the other part of this, and I don't want to put Corey on the spot, but I think her work speaks so largely to it. It combines some of the conversation for outcome setting and what John talked about with Recover Capital before. We do know a lot, right? Like the definitions don't particularly matter. We know how to improve people's likelihood to thrive, flourish, or enter recovery, if you use that language. However, what we don't know a whole lot about, but there's research trying to come out, is what do things like discrimination, microaggressions, allostatic load, systemic disenfranchisement in this country that absolutely impacts the people's ability, especially if they're BIPOC, if they have different non-traditional gender identities in our societal zeitgeist, that the intrinsic methods we have to build recovery capital are largely driven by what it looks like for people that look like me. And that we don't know enough about the other, right? So even if we have an intervention that could work, we also have to contend with how do we address the systemic issues that are in large part impact whether or not people, not even if they can access the services, but even if they can, I can get a peer, great. But if I can't overcome systemic failures in the United States, how am I going to thrive? And that's something we have to bring into this conversation too. And there's many more like Corey and others that are doing such great work there that I hope I can comment, because I'm not the mouthpiece for it, but I think it's important to discuss.
Great, I'll go next. Thanks, Rob. I'm gonna actually instead just feed right into what Rob was talking about as we start to talk about racial health inequities as well. We've talked about recovery capital and the importance of this. What we know about racial health inequities in recovery, we know they're caused by disproportionate exposure to different risk and protective influences. Sometimes today you hear them called the socio-political determinants of health. Bill White actually started to talk about this a little bit in the form of negative recovery capital. I called it recovery-related discrimination in one of my papers, but we know that racial health inequities in recovery are mostly due to mechanisms at the structural, organizational, policy, regulation level, at the macro level, less so of mechanisms at the behavior change level or the individual level. A lot of our research, even in racial health disparities, has focused on individual change as a mechanism, and this is part of why we have seen limited and sustained improvements over time. For example, our healthcare system is something that has glaring health and healthcare inequities in it. We know that the odds of people receiving medication for an opioid-related medical visit, it's low to begin with. White individuals are getting about 23% of the time, according to the New England Journal of Medicine. Black individuals, half of that, despite the fact that they both had 6 visits on average to the doctor. Unfortunately, I have to tell you that naloxone co-prescription had the exact same trend. It was being prescribed at half the rate to Black people compared to white people, while Latinx was just about somewhere in the middle, just a few points below individuals who are white. And now we also have studies showing that Black people are getting lower dosages of their medication for a shorter effective medication time as well, is all starting to come to light. A social determinant of health that is causing health inequities, huge, glaring, is going to be the criminal justice system. Black and Latinx people make up 77% of those incarcerated in federal crimes and federal prisons for drug crimes. The problem with this is it reduces your likelihood to receive care, increases your likelihood of a fatal drug poisoning. And so the focus of the research moving forward, and when it comes to racial health, it needs to be about identifying mechanisms of racial health inequities. And the last thing I'll say about that is going to be, we need some racial literacy training though, okay? We're in desperate need for what I call racial literacy training. Race is a social construct. It is not an objective measure of anything, not ancestry, biology, class status. It is self-identified construct, the definition of which can change over time according to the Office of Budget and Management, which is actually doing it right now. It is similar to gender in that it is not a reflection of biology. This is crystal clear in the science, but the misunderstanding haunts our medical field. It fosters stigma and medical mistrust against the healthcare system. And you are seeing this in part as to why the CDC tells us African Americans are showing up 20 years later on average for care for heroin use disorder compared to their white counterparts. You're seeing the effects of medical mistrust. There was a recent study of 100 doctors done at the University of Virginia, which is actually where I went to school for my PhD. Half of them still hold false beliefs about biological differences between their Black and white patients. 59 of these doctors thought Black people's skin was thicker than whites. 39 of them thought Black people have denser bones. 20 thought Black people's nerve endings were less sensitive. We have a need for racial literacy. This is reflected in our science. We want to talk about kids for a minute. Let's talk about kids for a minute. Recent research on the perinatal opioid use disorder showed that when Black newborns manifest withdrawal symptoms, similar levels to their white counterparts, they receive significantly lower rates of pharmacological treatment. That's the first issue. The second issue is that the researchers explain this by proposing biological differences without even mention to the possibility of institutional racism, explaining why these children were having different levels of care. And the last thing I'll wrap this up with, in terms of racial literacy training that is desperately needed for scientists, I have very intelligent and well-meaning scientists and mathematicians who are telling me, you know, Corey, the racial health disparity in that study, essentially it's not real, because when you adjust for class status, it would disappear. Okay, so we need some training in this factor as well. The covariates that you're using to explain away a health disparity do not meet the qualifications for a covariate. In other words, being poor a covariate is something that you have to have such that can cause your independent and your dependent variable. Okay, but being poor does not make you Black. Being poor does not make you Latinx. We have a racial literacy training in science that needs to happen to understand that there are certain disparities that cannot be explained away by things that happened after being Black or after being Latinx. And so I'll go ahead and stop with that one. Thanks, Rob, for the setup.
Good. John, you got your hand up.
Yeah, I guess we're talking, there's a lot to talk about. There's so many things to talk about. And we're hearing lots of these things expressed, which is great. I guess I just want to zoom out for a second and look at the big picture, what we're trying to do. We're trying to solve an epidemic right now, epidemic opioid crisis, stimulant crisis, in the context of an endemic problem we have with alcohol and other drugs. How do we address this? And how does this issue of recovery support services fit in? I guess just to zoom out and remind us all of that. And as I did that, I just thought of myself as we're talking here on some very important issues. I'm Keith Humphreys. Many of you know Keith. He's a fantastic researcher, policy person at Stanford. You know, his remark was that, you know, in the last 100 years, the biggest impact that's been made in the addiction field are two things: methadone and Alcoholics Anonymous. Those two things that kind of arguably at the opposite end in some ways of the spectrum, at least ostensibly, but not in actuality, are the two biggest things that have had, you know, an extension to buprenorphine now in terms of the biggest impact in terms of
On the
saving
intervention side.
On the intervention side, correct, yes. And I think, you know, when we think about the treatment context, as we're doing right now here for recovery, how treatment fits into the process of recovery, the biggest thing I think we can do in the treatment side is to make clinicians, to sensitize and empower clinicians, number one, to become aware of this bigger picture of remission and stability, long-term stability, beyond just acute care stabilization, to really sensitize them to be thinking about not just how do I metabolically stabilize this patient, but how do I increase the chances this person's going to be 5 years from now living in remission and having stable remission and recovery down the road. And we do have good models now of this recovery-oriented system of care idea of using our more expensive clinical services in concert, in combination, braiding together those more expensive services with less expensive, extensive services, which are community-based, which we call recovery support services. We've got very good models and proof of how linkage to these services amplify and extend the benefits of the expensive care that we give in our clinical settings. We've got lots of cost effectiveness data on mutual aid groups like AA, on recovery housing, on recovery community centers, which are emerging. I would bet my house that these things are going to be cost effective, the things that we are going to start to study in the next 50 years, looking at these different options out there for people to choose from. I think, you know, one of the things that we can do is to open the doors wider. And this has been done in providing, you know, we talk about multiple pathways to recovery. It's very true. And we need to provide different flavors of recovery, different options that can attract and engage more people. Because vanilla is not everybody's flavor. It outsells all other flavors 10 to 1, but not everybody wants vanilla ice cream. They want a different flavor. And we've only been offering them largely one flavor. Vanilla is nice. Come on, have this vanilla ice cream. It's nice. Most people think this is nice, but rather giving them options to choose from. And when we give them options, we find that people will get involved in something. They'll get involved in something rather than nothing. And getting involved in something just the same way as we have, you know, fitness centers offer a variety, not just cross trainers, but 40 different classes, swimming pools, courts, you know, for racket sports, and a variety of different classes to try and attract and engage more people in the process of physical fitness. We've started to do the same now in recovery fitness, or fitness for recovery, in terms of having many more options in the recovery gym, as it were, that people can find attractive and engaging and get them moving. And I think it's this, again, zooming out, just thinking about how do we solve this crisis more effectively and efficiently. And I think it's doing that. You know, we talk about this ROSC, but we need to connect the dots here between our clinical and our recovery support services and give clinicians awareness, greater awareness of these things. I'll just end with this thing. Sorry for going on. One thing. We held a Recovery Community Center webinar. We invite for the thing we're doing with NIDA for R24. We invited clinicians from Massachusetts General Hospital who were addiction clinicians. They had never heard of a Recovery Community Center. We'd be doing a study for 3 years. People down in the next building over, addiction clinicians, didn't know what a recovery community center was. That struck me as, wow, you know, how could that be true when we know these things can really help people to sustain the very expensive care that we give people at taxpayer dollars expense, when we waste a lot of it because we don't do the follow-up and connect them to resources that can sustain that gain over time. And this is where I think we need to go more assertive.
Well, John, I know it's frustrating 3 years, but don't they usually say bench to bedside is 10 years? So you're ahead of the game. No, I'm sorry. No, but it's frustrating. And I see Ashley and Andrew, you have your hands up. I just want to put another asterisk to make sure in the conversation we have some time to get to questions of measurement, because I hear us expanding very appropriately the scope and the list of the important metrics and targets, and the conceptualization of thinking more broadly, more largely to bigger paradigms is so critical. And we heard the concept of a dashboard or vital signs before, and I want to come back to that just a little bit if later, because in order to be practical, it's got to be short and sweet. And when we say vital signs, it can't be 30 measurements, and it can't be all things to all people. We've got to be able to say, well, what are the core measures that help move the field to be able to track these kinds of things? But anyway, in a minute, Ashley, you had your hand up, and then Angela.
And Mark, before
Corey.
you go, I do, and Corey, I guess Corey's in line, then Ashley and Angela.
Oh, sorry.
I just wanted to do the nagging necessary timekeeping. If we're ending on time, we'll be ending in 9 minutes.
Oh, yikes.
So I wanted to say a couple of things and then maybe ask our John and John, please go ahead.
Yeah, Aaron, can I jump in for just a second here? Yeah, we have a break scheduled in 10 minutes, but there is an hour's worth of time cordoned off after that break to continue the discussions from this morning or this afternoon. So don't feel like you need, in the next 9 minutes, you have to solve.
Terrific, John. We're going to need 2 hours, but we'll
okay. Yeah, so one more 9 minutes
and
60 more, and then we can solve the problem. So
we want to do that. What I want to do is do a quick punctuation and then ask Carrie and John if there's anything in the next 8 minutes or so that we want this group to address in the allotted time, and then we can come back for those of us who can come back. I just want to do something that I think is provocative, but I think it's worth giving it a shot. I think we can call mission accomplished on a couple of things so that we can move on to the things that seem not accomplished. I think mission accomplished in defining recovery. I don't think we need to spend a lot more time on defining recovery. I think the definition we have work very well. The fact that it's tied inexorably to individual journeys. From my point of view, that is a service to the field, and it doesn't contradict anything that folks have been talking about here today. I also want to say mission accomplished. Recovery services is on the intervention continuum now. That wasn't true 20 years ago, but when we think about the intervention continuum, we talk about prevention, early intervention, treatment. Recovery services is now part of that continuum, and it's not necessarily sequenced and doesn't have to be. Neither is prevention and treatment, right? All 4 of those stages of the continuum, those are all social contracts, right? That's a person coming into a contract with a service and asking for a service and being part of it. That's important to note. I think that's mission accomplished. I think the next things that we're talking about here moving from thinking about treatment plan, I would like to just say, if I have one takeaway from the panel, it's the term treatment plan is now obsolete. And I think maybe NIDA can stop using it. I think it's a recovery plan, right? And you're in a treatment service, but what you're working on is a recovery plan. And if we think that way, then automatically we think not just about assessing substance use behaviors, which we all agree from a clinical point of view is important to do when someone's coming in for treatment, but we're automatically thinking about the recovery vitals, still to be defined, but we know that we have to cover recovery vitals, and recovery vitals include socioeconomic and social determinants of health. It's part of the recovery vital continuum, so that clinicians know, I got to understand the substance use behavior, and I have to understand the recovery vitals. From that point of view, then you go to the recovery plan, which is by nature person-centered, right? It has to be, because it's not in the hands of the clinician. And then you can have your cake and eat it too, right? Because then then you're driving the operations in a treatment setting that is being driven by the recovery plan, which is automatically person-centered. And if that person is focused on, as Ashley was saying before, things that are not the substance use behavior, that can drive the recovery planning. But for persons who are coming in and saying, I really need help with my substance use, then that does come first, right? And that's how the recovery plan operates. Anyway, that was my soapbox, which I am now jumping off of and turning to whoever was next in line. Corey, I think you were next in line if you still want to go.
Okay, I'll certainly be brief. And yes, that formalization of recovery capital and some recovery support services is now in the American Society of Addiction Medicine placement criteria formally as well. You know, the idea of we're here talking about these environmental aspects, and it's very difficult how to deal with these things in a clinical setting. But I want to highlight something that I've been seeing, watched and done, executed very well regarding that, using medical documentation to address certain social determinants of health. The reality is that federal and state governments have actually given providers a significant amount of authority to intervene in situations where a social determinant of health is affecting a patient's ability to follow medical advice or treatments. You can use medical documentation in various situations. You can help determine eligibility for disability housing or income, prevent utilities from getting shut off, improve housing conditions, avert incarceration, reducing court fees and fines, help with immigration issues, transportation issues. In fact, a study in JAMA found that physicians provided letters that explained fixing a housing issue from a health standpoint. Landlords addressed the issue 89% of the time when they received a letter from the physician. You just got to give 2 copies to the patient. You keep one, give this one to your landlord if you're in subsidized housing. For example, mold is causing asthma exacerbations. A leaky tub is causing an unsafe living environment. So ultimately, clinicians and health systems need to recognize the power they possess. It goes beyond screening and referral. Health systems have overlooked and underused their ability to address these barriers, making it difficult for patients to manage their care, and sometimes making treatments ineffective. And so I just want to point that out as well.
No, that's very interesting. And I didn't get that class in medical school, but it sounds really important. And it's something that we have to empower people to do a better job with.
And if I can follow up on that with it's what Corey said, I feel like healthcare professionals may be more willing to deal with the leaky toilet that is impacting someone's medical condition versus getting them to connect with a recovery community center to address their substance use. I think, or they may not even know about. They'll know about the how to fix the leaky toilet before they know about how to help someone connect with recovery support services that's down the hall from them. And it is, I think it's the healthcare and the insurance companies and that realm that needs to be where the finger needs to be pointed, because I think we have to keep in mind that these recovery support services are being started and run by people who have experienced the stigma from the healthcare and insurance system. And so there are so many people, there's so much grassroots energy, so much going on, but I think that disconnect we can't put this on them to have to solve. I think we have to make it be changes and things at interventions that happen at the healthcare system, the insurance system, that level, to bridge this gap. We can't put it on the people that have been stigmatized and pushed out by that very system.
Yeah, Ashley, I couldn't agree more. And I had my hand up before, and I know we need to finish, but that's exactly sort of where I was going, is what is the role of the healthcare system, not only in connecting folks to care for their substance use problems, but also early intervention. And we're talking about recovery vitals. We can talk about behavioral healthcare vitals from sort of the primary care system. How are we checking in? Folks do go to the doctor often or go to the ED, and how is our health system sort of identifying risk, identifying what's needed, and connecting folks to care. And if our addiction medicine folks don't know that there are recovery community centers in their communities, I feel quite confident that our primary care physicians also don't know that.
For sure.
I think some of this conversation leads nicely to, there is one question in the Q&A. Rachel asks, I'm curious if providers have experienced any difficulties in advocating for more types of treatment to suit the multiple ways people respond to said treatments due to economical challenges posed by insurance companies, hospitals, and state funding. So that's, I think, related to what you all were talking about. And I think after, if anyone wants to provide a response to that, we can take a break after that, and then I'll turn it to John to talk about the break, and that's his role. But does anyone have a response to that question? If not, we can ask people to put things in the chat.
Yeah, go ahead, Rob.
No, you deferred last time. You go first this time.
I'll be quick so you can get a minute in too. Now it's very difficult to continually implement best practices that are changing all the time in clinical settings. And we typically will train clinicians to implement a certain procedure. And we need to be more nimble and adaptable and have the resources to be able to train and adapt the clinical workforce to innovations. And this is a big challenge. There are philosophical, ideological challenges, of course, which I think is in the question as well. But there's also the issue of being nimble and training our clinicians to keep up with best practices. The other thing, of course, is that, and I will end here, is that even though clinicians might think they are implementing the evidence base, they often are not, in actual fact, when you observe them, even though they say they are. And this has been shown in the CTN, for example. I'll pass to Rob.
A slightly different approach, I think, we have unique circumstances within our mixed payer market, right? And we also have geographical variance, based on state law and policy as it pertains to pre-auth. I think while we have certainly seen more impact and positively around the access to things like MOUD and other forms of pharmacotherapy, as well as other truly evidence-based services. The problem is, I think we're starting to see the ripple effect on the other side of, while an intervention and perhaps not treatment, we still see very little coverage of peer recovery support services and other social determinants of recovery interventions and services. Those certainly on the commercial side and CMS, we're starting to see positive movement there. So I think on the treatment side, as it concerns pre-auth and having to do advocacy there, it's gotten better in some areas. It still is abysmal in others. And we're starting to see the next wave of the same exact thing we saw with pharmacotherapy, is that the community-based services we have spent so much time talking about today as complementary to an integral and sometimes the only thing offered are covered very rarely, right? And I think we have other governmental payers in terms of like the substance use and mental health block grant that were meant to promote innovation and pay for things that couldn't be covered otherwise, that are no longer doing that, Medicaid expansion or not, because they're used to supplant and sustain treatment as usual because of our mixed payer system and the lack of funding. So there's certainly advocacy to be done, but it's not just on private insurance. I think we have a lot of work to do on the opioid settlement dollars, reformatting and using the block grant to its large intent. And we need to start contending with these other things that we know are already working, and to John's point, are likely going to be found to be cost effective over the next 50 years, to make sure those things get covered now in the same way we did for MOUD as the clinical and medical treatment over the last 20 years.
If I can throw in very quickly the three things. One is needing to have a barrier has been needing to have a substance use goal when you instead you need to work on the things that are going to keep the person in treatment and keep working towards improving their relationship with substance use, and having to meet the definition for substance use disorder and prove that. And you have to gather the information from a young person that doesn't want to tell you things in ways that will help them meet the definition for substance use disorder. Second one is social support network. When there's someone that's a concerned significant other, and being a clinician and wanting to provide them help and not being able to have a mechanism to be able to do that within the current system. And then the length of time that it takes to actually get recovery capital built for sustainability for long-term success does not match up to the way our treatment is funded in our country right now.
All right, is it break time?
John?
Yeah, yes, it is break time. So we can continue this conversation or the cross-pollination with the conversation this morning. We have an hour slated, but that's not obviously a hard and fast deadline, but we'll reconvene at 4 p.m. So 15 minutes or 13 minutes, and get the rest of it on the table. But thank you very much for this session. This was great. Give everybody a chance to caffeinate and settle back in. If you are here and could turn on your camera just so we know that you're here, then Mark and I don't have to just talk to ourselves. Waiting to get. There we go. Okay, so we got 3 rows of people. So I think we can get started. So the goal for the last hour, and it, again, we've got the room for an hour, but the goal here is to give space for any conversations that were cut off or truncated earlier in the day, or to ask any follow-up questions or connect any of the dots. And one of the ones over break that we were talking about was a little bit of discussion about this idea of recovery vital signs and what those would be and how that would be constructed from a clinical standpoint, both as an answer in and of itself, and then also to set the stage for the session that we have scheduled for Monday from the research side to see what kind of measures and things that can be provided to help improve the efficacy and improve the sort of services that are available at the individual level, because that seems to be one of the big themes for today, at least. One of the first ones that pops out is the individuality of the recovery process. So I'll turn it over to Mark and Aaron to talk about that and anything else that folks want to talk about as well.
Yeah, so just as a first next topic, I'd like us to talk a little bit about that idea of a dashboard or vital signs or a measurement set. And I'd like people not so much to think in terms of research measures. Let's talk about core constructs and core essential concepts that will drive us forward. And then in a later date or in the tomorrow in the next conversation, people can talk about what the actual instruments are and can get them from 30 item instruments with item science, to 2 items. But what are the core constructs and how do we use those to shape practice as we would in thinking about a dashboard or vital signs? And one of the fundamental problems that besets our field is that we don't have a core set of measures. We don't have a core set of staging criteria, the way, say, for example, our colleagues in oncology might have with the tumor nodes MET system. Every oncologist has a way of staging any cancer with three items: the size of the tumor, the extent of positive nodes near the tumor site, and the existence and extent of metastases as a staging for prognosis, treatment matching, and testing of the efficacy of treatments. And that can be dynamic, not just as prognostic, but as a treatment response tool. And we don't have agreement on that. And we've been talking today in a very productive way about expanding the set of things that we consider, but I just want us to be mindful that we can't have it all in a 15-minute office visit, as I'm just thinking about what a clinical encounter is like. So how do we focus us down? During the break, I was trying to think, well, what are the core things in a 15-minute office visit that I want to get?
Actually, Mark, well, I just want to interrupt quickly because I just want to note that we can even up the ante a little bit as we dive into this very important topic in the following way. I don't think that this is going to be or needs to be just an academic exercise, right? Because we could imagine NIDA putting out an RFA where they were looking for research on recovery vital, measure recovery vitals. Let's get some research. There are measures and studies that we can stand on that are already getting us started in this direction. And let's think about a tool or a set of tools that really could be used at scale, not only in clinical/treatment offices, but also in recovery service settings, right? A set of tools for tracking these, what we call these recovery vitals. So I think that this doesn't just have to be an exercise that's carried over into Monday, but is something that can really have upstream impact and can really make a difference. So I just want to sort of put that out there and then turn it back over to you.
No, that's exactly right. Anyway, I was thinking, what are the key things that I want to get? And I haven't thought this through, and I'm sure other people have articulated this better, and in no particular order. I thought of 5 broad categories, and drawing on much of our conversation today. One is at a kind of a very clinical, pathological kind of encounter sense. I want to ask somebody about their symptoms. What are their concern? I want to ask them about their service utilization or recovery efforts. Are they clinical? Are they not clinical? But what are they doing about those kinds of things if they're trying to address those symptoms and address change? I want to ask them about what the response has been to either treatment or recovery efforts. I want to ask them about what their flourishing, broader human happiness goals or recovery capital is. Is that the bark? Is that van der Weel's flourishing scale, or is that just kind of an English language conversation? And then I want to ask them about their overarching aspirations, or as Ashley called them, their values. I'm not saying those are necessarily in that order, but those are the kinds of things that I want to hit on every time, I think. But I don't know if those are the right categories or what other people would say. But I do think that we do want to identify a core set, because I think it would drive training and practice in a meaningful way. But others, John, you have your hand up.
Yeah, just building on that, and I think Carrie put in the chat that this is the group discussion. So folks from the first session as well, please speak up, because one of the things, Mark, what you were saying that struck me is the idea of, what are the goals? What are the individual's goals, and how can those questions be phrased in a way that's accessible or articulatable for people who, because we heard a lot in the first session about the sense of self-worth and the identity and the purpose that went along with the process of recovery. So how do we put that into the mix here? How do we systematize that as well? So what questions to ask or delving into that as well?
John.
Yeah, thanks. Great question. I think a lot of I think it depends on what vantage point, what viewpoint you're looking at. Mark, I think we're looking at from the clinician's perspective. Yourself as a clinician, what questions would you want the answers to? I think there's also the kind of the patient perspective. What are their goals, and how do we track those and measure those? so that we can demonstrate for them and for us as clinicians that they are improving in the ways that they want to improve on and have metrics. I think from the payer, stakeholder, other stakeholder, legislature perspective, I think they want to know, and there is some overlap here, but they don't care about whether patients are flourishing or not. What they care about is, are they overdosing? Are they transmitting infectious disease or contracting it? Are they using expensive services like emergency departments and overnight stays in the hospital? Are they getting arrested, and are they employed? Those are the major metrics that legislators care about, policymakers care about, public health people care about at the macro level, which is some overlap. Of course, we care as clinicians about overdose. We want to prevent overdose. We want to prevent them going to the emergency room if we can help it, and going into the hospital again, because that's a marker, obviously, of severity. We want to prevent infectious disease contraction and spread. And we want people to have structure, whether that's employment or some other occupation that can give meaning and purpose. And we don't want people to get arrested. So I think a lot of those things are relevant to our clinical settings. I find myself that a lot of clinicians are not aware themselves of what they're actually trying to target. What are the intermediate mechanisms that they're trying to target? For example, if you ask residential treatment providers, what should change between intake and discharge in a residential setting, or you do outpatient. What should you see change between intake and discharge? A lot of them are kind of stumped. You know, they're not.
It's amazing, isn't it? It's amazing.
It is amazing. And that's kind of, because we're not really thinking about it like that. As providers, oftentimes we just think, oh, well, they're going to be here for a month. We're just kind of like, hit them with everything, and then they're going to get discharged in 4 weeks or whatever, or 12 weeks or at the end of the IOP. And what are our what should be the decision point? To your point, or someone made this point earlier about staging. Once they reach this stage, then they should be go over to a different level of care because they're stable. And other than the vital signs, the actual physical vital signs, we're not very good at measuring the other kinds of vital signs, psychological, ready, willing, and able kinds of vital signs. And I'll shut up now, but anyways, a few thoughts there.
Ashley, you've got your hand up.
So this isn't going to happen in like the 15-minute visit, but to answer John's question, the panel earlier today told us, right? I wrote the financial stability, a meaningful job, purpose, finding community and acceptance, feeling belongingness in your ecology, finding your place in the world, ways to fill your time with meaningful things, including helping others, and also self-care, pursuing happiness, finding a lifestyle, learning how to live, having the skills to cope, manage cravings, weather the hard times, and manage the pain. I mean, that's what the clinician should say, right? That's what we would hope the clinician say. That's what we're trying to get to. But I don't know how to. I don't know how to measure all of that in a quick office visit.
But and also, and I know Mark didn't intend this, right? Medication management visits usually happen in a 15 to 20-minute session, but there are also behavioral interventions that happen over a much longer period of time. So we're talking about the clinical setting, right? It's not just what happens in the psychiatrist's office necessarily, but what can happen for any kind of behavioral intervention setting, and where a treatment or recovery plan is played out over several sessions and sometimes several weeks and months.
You mean you get 20 minutes instead of 15 minutes?
If, as John say, the insurance companies are willing to pay for it, right?
Hello.
Yeah. Calvin, go ahead, please.
Great, great discussion and comments that And I wanted to come back to this issue, Mark, you've raised about what can be done in the 7-minute visit or the 8-minute visit. And maybe our fix, because couldn't some of this information be collected? Well, I think about like my latest visit to my physician's office, and I had to complete a few forms before I entered the hallowed place, right? But some of this data can be collected. You don't need the physician time to ask these questions.
I
And
just put that comment in the in the comments box. So I agree.
Yeah.
or
Great minds think alike.
or you know, the questions I get through my health before my visit on my app, right? Saying answering these questions, things like that. So ways we could standardize the collection of that in some mode that doesn't take, that we don't have to go to payers to ask them to pay for it, because that we'll be waiting a long time for that, right? What are the things we could do now, information we could collect now without very much effort? I just want to kind of emphasize that.
Delvin, I love that. I love the reminding us about health information technology and how it works. And also wanted to keep us on track with, if we were to ask in this way, do we know what to ask about, right? Ashley hit us with 15 questions, some of them narrower, some of them broad. It's interesting, right? What would
Just want to
that
reflect, they
be?
weren't mine. That was what this
Yeah,
the
no,
astute panel earlier today came up
And
with.
the panelists, right? She crowdsourced some ideas. Robert, please.
Yeah, I think there's been a lot of good commentary thus far. I do wonder, right, the somewhat of a fallacy, at least in my mind, thinking of how and where and when people get care, that I think most people treated for substance use disorder very rarely see a physician.
Well, that's a good
Perhaps they
point.
see allied health, medical staff, but depending on the type of treatment setting, right? More often than not, they're probably seeing clinicians where they're getting 30, 45, 60, 90-minute sessions, depending on where they're at in their level of care and depending on what they even engage with. But I think it allows us to think of our larger continuum of care. What should actually happen after that, and who should be collecting this data? Who is well skilled and has long-term engagement outcomes, long-term engagement trajectories, and we've talked about them today. And I'll toot their horn again, right? But it is peers, it is community healthcare workers, and is in the community. It's where people exist for hopefully as long as they want to, because people have choice, but at least 5 years of getting some level of acuity or intensity, where that engagement and collecting those type of outcomes isn't just to promote the collection of outcomes, but is actually used in service delivery, right? And that is
Yes.
RCCs and other peer workers, because the type of data we want is already being collected, right? Like if we want to know how to track and collect and report on these outcomes, they're in the service engagement history. We can take an analytic health services research approach and look at changes in housing and employment and recidivism. We can look at the completion of recovery plan goals and changes in recovery capital over time. We can use in the advent of artificial intelligence to model this stuff out, where we can stop berating people with survey fatigue and use the data we already have in the course of engagement history, if we can get them the engagement at the community level, which can be paid for, right, but requires some revitalization. But I do think on some level we should change somewhat of the conversation, because the people that I know and work with, right, the 40,000 people we've served at our RCO in Pennsylvania and Texas over the last 5 years, they see us a whole lot more than they've ever seen their medical and clinical staff. We are the best positioned to collect these type of outcomes and report on them in partnership with clinical and medical care. But that service engagement episode with clinical and medical is short by comparison.
Yeah.
All the more reason, right, Robert? It's terrific, and all the more reason to remember that recovery services are an integral part of what the continuum of intervention is, number one. Number two, it's not going to be a very good recovery vitals tool if it doesn't have equal weight and is used at scale in systems of recovery as well as in the treatment system, which is, as you say, is much less accessed. Shelley, you have your hand up.
Hi guys, sorry, I'm off camera because my husband's cold has finally caught up to me. I just wanted to sort of challenge a little bit, Robert, what you just said about the routine data collection about some of these socio-environmental or social determinants of health factors. I'm just thinking, as a patient who sees a PCP or any medical professional, no one ever asks me about this, right? Like, they may have asked me about cannabis use when I was pregnant, but that's about the extent of drug use questions that, so I think, I don't know what health setting recovery services live in? I think that's one question. And then, you know, I would just ask if there are any more folks with lived and living experience still on the call. If you want to, you know, try talk to us, like, how would you like this information to be gathered? Don't even think about payment and I mean, think about burden, but you know, tell us, like, how would you prefer this information? Is it important to gather? I think the answer might be yes. And then the question is who and how it's delivered.
I will just say mainly because I've, and I don't think you did this on purpose, but I've been rendered invisible a lot in my life. I am a person with lived and living experience. I'm a person in recovery. And I say that only because oftentimes that gets rendered otherwise. So I want to hear from others, but I also want to make sure that who I am is not rendered obsolete.
The person I know that I'm closest to with a long resolved lived experience of opioid use disorder continues to have a policy of basically hell no when it comes to telling her primary care physician about that past history. So that's what I know about that.
Thank you, David.
Yeah, I know my thing is weird. You can't see my hand up because I have a mirror back there, which is really weird. So it just.
I got you. No, I just found that. I'm going to pay
Yeah.
attention closer now, closer attention. Go ahead.
That's all right. You think maybe I'll rearrange my room so that it abides with the Zoom. Just piggybacking on what David said, I think really a lot of this, especially with your PCP, is really going to be around the level of stigma that you have endured with your recovery journey for most of your life, whether or not you're going to be comfortable. And so for me to say I'm comfortable with it, you know, is totally, I think, probably irrelevant for you know, asking other people. But I can definitely speak to my lived experience. I would love for my doctor to acknowledge and even ask me about my recovery. You know, they ask me about a lot of things that I'm, you know, the medications that I'm on, how my blood pressure is, all that kind of stuff. I make it, you know, I'm very forward about my recovery status. Anyone that knows me for more than 5 minutes, whether it's a health professional or whether it's just a person on the street, is going to know that I'm in recovery. And so I've made it very adamant, or I've been very adamant in you know, saying, you know, the whole time. I just got a PCP when I moved to Boston last year. And, you know, I've seen him twice now and he's never asked me about, you know, anything to do with my recovery. And so, you know, just even acknowledging it and just even, you know, including it in my, you know, in the work that he does around just asking questions would be absolutely wonderful. It's just not, and again, I'm not going to any kind of addiction specialist or anything like that. This is just my PCP, but this is part of my history and this is part of my, you know, my health history. And so I do think it would be important to at least touch on those things when a person, you know, like myself goes to the doctor's office.
And Noel, I'll just take the opportunity to say this. In youth services with which I'm most familiar, there are some models for this, right? Depression screening, a depression vital. The questions that are asked in pediatric primary care are very similar to the questions that are asked in specialty care for depression or anxiety, are very similar to questions that are asked in school-based settings. So there's this idea that there are depression or anxiety or internalized distress vitals for young people that are commonly asked. And if they were part of that person's depression recovery plan, would follow them. A question in front of us, not to make it too narrow, but just to sort of keep this on the table, not in the background, but in the foreground. What would those vitals be if we could wave a magic wand and get it so that the primary care physician and the psychiatrist and the residential treatment setting and the recovery services folks and recovery community centers and recovery high schools, of all those places we're going to keep recovery vitals, what would they be? Because before we can get to the technology to make it work, we have to have the constructs that we would put in front of them that would be the most worthwhile ones.
I want to speak up. I'm not a person with direct lived experience, but I do have indirect lived experience with multiple generations of my family. But in addition, I've also had the luxury of being able to work with community boards of individuals who are in recovery. And one of those boards is a group of young adults who are in recovery. And we had a meeting with them one time where we were talking with them about a research study that was focused on pregnancy and postpartum and substance use during pregnancy and postpartum. And it makes me want to urge maybe a little bit of caution when we're thinking about physicians and other healthcare professionals assessing these things, because the stories they told us led us to, they no longer tell anyone in the healthcare system that they are in recovery, because most of them were in this board at that meeting were women. And they spoke about the stigma that they receive for regular healthcare because of being in recovery, being a woman in recovery. And they talked about going through their own pregnancies or abortions and other healthcare, and how they were impacted because the person knew they had a history with substance use, of problematic substance use. And so it does make me realize we need to think about that. And Kayla mentioned in the chat the education for healthcare providers, and it's a double-edged sword, I guess I would say, for some individuals. And I think for BIPOC communities as well, I would imagine the same thing would be true as well.
I want to agree with that, Ashley, and agree with Brenda saying about CPS referral. And again, just to sort of remind us, in a primary care context, first of all, a lot of those visits are only 15 to 20 minutes. Second of all, a lot of times a primary care physician doesn't want to ask about substance use of any kind, because primary care physicians hate to ask a question to which they do not have the answer. And I'm married to a primary care physician, so I have lived experience with that. So probably most of the time what we're talking about in terms of recovery plan doesn't happen in primary care context principally. It's principally in contexts that are substance use specific for the most part. I would imagine that's where a tool like what we're talking about would have the highest value. Kayla, please.
I have like two different comments, but I just want to piggyback what Ashley said. I was 6 years into recovery when I had my son, and he was born early. No reason at all, just it's within my genes. And the NICU staff and the hospital staff, knowing in my chart that I have history of addiction, the way I was treated, I'm sure is completely different than someone else. And my son, the way he was treated, I'm sure was different than someone else. So there needs to be such a push for education if this is going to be something that is within office visits. But I think really like getting back to like, what can we measure? I think really like looking at, are you connected to your community? Are you connected to peers? Because we know substance use disorders, we know addiction like manifests in isolation. The opposite of isolation is connection. And so are you connected? Doesn't matter how you're connected, but are you connected? We also need to look at, okay, what kind of mental health symptoms? Do you have an anxiety, depression, PTSD, gauging all of those types of symptoms? Because if the person is working on those types of things, it's going to help them within their recovery. Looking at self-worth. How do you view yourself? You know, like, what is your dialogue in your head? I also think looking at, a lot of us have talked about purpose. Do you have a purpose? Do you feel that you have a purpose? Are you like, not necessarily saying like, are you of service, but a lot of people talk about like earlier today, are you of service? Do you have a purpose? Do you feel you have a drive? Do you have a goal? And I think that's another thing, like, do you have goals that you're working towards? Because I think regardless of what our path into recovery or substance use is, if we don't have goals, I think anyone, if no, you don't have goals, it's not a good sign. But we need to have goals, whether that is, I want to run this race, or I want to go back to school, or I want to improve my finances, but like looking at those things. And I think those are like, yes. And Ashley said, how do you fill your time? You know what I mean? Are you sitting around playing, maybe video games are okay, whatever. But like, what are you doing with your time as well? You know, and what are you doing to improve yourself? But I think those are things that could be asked and could kind of gauge how someone is in their recovery.
Kayla, I just thought I heard you say 3 things, which I thought were really terrific. And it was more than I'm sure, but I thought I heard you say, one dimension is what's the system of relational support and responsibilities that this person has? Number 2, what are some of the other behavioral health and co-occurring issues that the person is contending with? And number 3, what are some primary goals for achievement or flourishing, right? What's first on their agenda for what they want to accomplish? So those are very powerful. Anybody, other folks?
Hey, Erin, it's Angela.
Oh,
Yeah.
go ahead.
I did have to step away for a few moments, so I'm sorry if this comment is out of context. And I dropped it in chat a little bit. I feel like the conversation now is sort of around what can be identified in healthcare settings. And I do think that folks do access primary care maybe more than we're thinking. And SBIRD has a long history. I don't know how folks feel about it anymore. I know we've really struggled to implement it here, but there was a huge shift when we integrated peers into our SBIRT projects here in primary care clinics, and also not calling it SBIRT, calling it behavioral health vitals. And so there are a number of vital signs and screenings that can occur within that context where the nurse does the triage. And then, with a limited 15-minute window, I understand that they can't go too far into sort of all of these pieces that we're talking about. But I do think there's a great mechanism that can be borrowed from, that's already sort of set up in a lot of healthcare systems, if not to refer folks to treatment to prevent the development of substance use disorder and to, intervene early. So I don't know if that's been mentioned at all.
I think it hasn't. As someone who's also working on an SBIRT project, I not only second that, but I love the fact that we can transition away from a term that maybe doesn't work, but not in any way step away from the processes that are very important, right? There's nothing more important than a good continuum of care, right? Of which SBIRT is an example. John, please.
Yeah, I think just thinking about, what's feasible to capture longitudinally with patient care. I think just from speaking from personal clinical experience in implementing measurement-based practice, a lot of patients really like improvements in their substance use, so in their alcohol and other drug use, which is really bringing them into treatment. That's why they're there, because of an alcohol or drug problem. And so showing week by week improvements in that and feeding that back to them from personal experience is very valuable for a couple of reasons. One is that it can really help them understand that they are making progress. Sometimes they don't feel like they're making progress if they're still using, but you can show the percentage of days improvement, for example, in days, longer periods of abstinence or less drug use. And they like that. When you show that to them graphically and feed that back to them, that can instill hope that they don't give up and that they keep moving forwards. Other things that I found helpful are things like symptoms of depression and anxiety, kind of global symptoms, capturing those nimbly and concisely and feeding that back to them also over time. They like that. They like to see that their reductions in substance use or elimination of substance use results in improvements, correlated with improvements in depression, anxiety, optimism, and hope. These kinds of things, they like that. They like that. They like to, those are the kind of core metrics. Other things that I implement are things that, again, that are in keeping with their goals. So whatever their goal is for coming into treatment, they may be wanting to get a job or go back to school or other metrics that can be. You can easily design these metrics as well and implement them, and that can, again, feeding that back to patients over time can instill hope and optimism, just to show them that they are making progress. So I found those things to be very helpful, and again, in collaboration with the patient in understanding what they want measured. And again, I usually have this standard set of measures which tend to be broadly applicable, and go from there.
Outstanding. Outstanding. Rob, please.
John, you may still be my favorite clinician. A battery of vital signs is the word we're using, and then allowing people to choose what's actually important to them is music to my ears. And it's related to what I was typing out, and it was like, I'm just going to say it, but no matter how we construct this or where it goes from here, and the constructs we choose to elevate into any type of recovery vital signs, I think whatever that final inclusion is, a standardized way to actually ask, in this case, the patient or the recovery, what is most important to you, right? And even if it's Likert type 1 to 5, let's rank these and let's prioritize what we include based on what is important to you. Because if we go back to the example around how do you spend your time, right? Like that certainly could be broadly applicable to some. It may not be at all important or an indicator of success to somebody else. I think we need to also include to people, we're not going to put you in this box where we know these are the things that we want to measure for you, even if they are broadly applicable. What is most important to you so that we can rank order prioritize those and know how we weight those scores to push any output, right? It's similar to Brothenbrenner's theory that in ecological systems theory that the mere presence of things in these ecosystems isn't the complete picture. The perception of the utility of the potential benefit to, in this case, the person matters just as much, right? And I think we have to look at that in terms of outcomes measurement and vital signs is what do people think is important? So any standardized list I would think has to include that element of actually asking the person, where are these at in your priority schema? And then use those to weight any final output to actually be construed as a practice-based tool. It needs to be something that we look at as we kind of construct this broader approach to recovery vital signs or recovery measurement, because that allows us to get closer to the, where I started, at least on our panel, to precision-based healthcare within behavioral healthcare vis-a-vis recovery, bringing the person back into the equation another level.
And Rob, I would agree with that, and I would add to it one friendly amendment, which is that usually I get alignment with patients in collaborating over those patient-driven priorities, but not always. And the act of explicitly addressing misalignment as we build therapeutic alliance is in itself very, very productive in exploring what we agree and don't agree on and getting to how we're going to do better to collaborate. Because sometimes there is non-alignment, but it's important, as you say, to ask for the sense of and emphasize the sense of what do they prioritize.
I think it's a good point as a non-clinician and non-medical, right? And my background of recovery support services, anything that we don't have alignment on, we would drop. So I'm purely sure that is true, and I could see the value in it. But it's one of those tensions I think that has to be navigated too. Because in my world, there would be no amelioration of that tension. We would always err on the side of the person, regardless if we believe in the disease model, regardless of hijacking the prefrontal cortex and et cetera, et cetera. But I think that is, as we look towards integration and doing this at all levels of the continuum of care, that it will be one of those tensions that has to be further navigated.
Yeah.
That's really what's up. Robert, I'm glad you said this out loud instead of just in the chat. That was terrific. And I'll also mention a lot of times the tension that a clinician will point to is not necessarily from the clinician making the tension, but the tension that exists in the contrast between a person's stated goals and what their current behavior is, right? The foundation of motivational interviewing is this idea of pointing to a discrepancy that the client has in themselves and helping them think about, okay, how am I going to resolve or address some of these discrepancies? Noel, I do see your hand.
All right, great. One thing, Robert, got me thinking about it because I had seen this paper recently, and I've seen a couple of socioecological models around kind of the continuum of care for substance use disorder kind of generally. But the new paper that Katie Wickowitz just came out with is great because there's a socioecological model for like entry into substance use disorder, but then there's also a separate socioecological model for recovery from substance use disorder. And I think it's excellent. I just copied all of the things that she had kind of at that community and then at that interpersonal level of the socioecological model that she had. And I'm going to throw those in the chat right now. But I think that particular paper really stands out to me as far as maybe a starting point or something to kind of guide our thoughts on what would be important for the recovery phase, I guess you would say, of the continuum of care.
Oh, thank you so much. John?
Yeah, just again, coming back to, it's great conversation. Just coming back a little bit to the being a bit more strategic as well as clinical, but strategic in the sense that we are a very stigmatized field. We are a very stigmatized people. And to remember that as we try and ask for funding and coverage for services, from public health and public safety standpoint, legislators, payers, as I mentioned, they're interested in in things, and I think programs are as well, and particularly recovery support services are very interested in the impact they're having at the community level, public health, public safety level. So I think somewhere somebody needs to capture, for the sake of the recovery support services field and clinical services field, that we can demonstrate reductions in overdose, infectious disease reductions, reductions in expensive healthcare utilization, reductions in arrests, and increases in employment. If we can demonstrate those, it's the sort of thing that politicians can brag about, that we've implemented, we've invested in these recovery support services in our community, and look at the reductions in these areas that we've been able to show. They're not so interested at that level in, how many people got connected to other people, but the endpoints they are very, very, very interested in, because it costs the state a lot of money for arrests, for expensive medical services, for people not going to work, which is the major contributor economically to the economic burden attributable to these disorders, and paying taxes. So all of those things, and infectious disease transmission, very, very expensive to deal with. So if we can reduce those things and demonstrate that we are actually doing that in our clinical and recovery support services settings, it really empowers policymakers to make a case for expansion of these services. And so I think we should pay attention to those things, in my view, as well as the kind of more person-centered clinical metrics as well.
Don, thank you so much. And I know Ashley's next, but I probably shouldn't do this because it steps outside my role as a moderator, but I would love to hear more from Corey about the way that she's measuring vitals currently, sort of what some of those constructs are and what meaning that could have. But Ashley, your hand is up.
I just say I think it's a conundrum of how do we when we're coming at it from clinical healthcare settings, and how are we going to get people to tell us some of those things, and so then it does make me wonder, would there be predictive models that we could use to say to find the things we could potentially get someone to, the things that Kayla talked about, like that maybe you won't talk about your substance use or things, but you would talk about your goals, or where you spend your time and who you rely on for supports, and things that someone would tell us about, so long as we could have them know how predictive they were of the other things like the ER visits and the transmission of infectious disease and those other things. And so if there's something that's the the mediator that we can assess that we can get the information and get it reliably and accurately, validly, and also meet the needs of what we know the legislators are going to want to hear about.
Lovely.
I'll go ahead and address Aaron's.
Go ahead, Corey, please.
Yeah, I'll address Aaron's question. Regarding the recovery vital signs that I was talking about before, recovery capital, yeah, like I said, it's in the ASAM placement criteria. It is not required at this point. What they tell me is when insurance companies require it is when it will be required. So that starts to get closer to a leg there. At the same time, that is validated on SUD remission. Okay, and so that's a good indicator. I also do like quality of life because I can make comparisons to the general population. That's how I know it takes about 15 years of recovery to get your quality of life back to that of people who do not have substance use disorder. The sustainability issue of the indicators that Dr. Kelly brought up is huge. Those things are huge. Our data points are often too narrow, and therefore we cannot speak to the relevant stakeholders. And what he's doing is kind of giving you a foothold into a lot of different stakeholders at that time. We get those data points, well, probably about as long as the BARC 10, everything he just said right there. And so, and that's how we work to try to keep systems alive, is keeping the language in our data points that those people need to hear and understand. Honestly, talk to somebody outside of recovery, an insurance payer, a politician, say the word recovery capital, they do not know what that means.
That's
Talk
for
about
sure.
overdose, talk about, have you been using shared needles? Talk about any arrest, they know what that is. So you gotta also learn to expand our language and what we're talking about across and outside of the recovery field too.
Yeah, that's so important.
Yeah.
So Corey, I have another follow-up question. It's not just that I enjoy talking to you. So how close are we to having a battery, to use Robert's term, a battery that we would consider a recovery vitals battery in your point of view?
That's a good question. You know, I'd probably also let Dr. Kelly chime in on that one. I mean, there's standard measures that we often use every single time, right? In our studies, by far. So are the data points that he's talking about. Where it also gets tricky to me, this issue was kind of touched upon earlier, is the day somebody says we don't have a high enough recovery capital score, you're not in recovery, we're not paying for the services. There's my worst nightmare right there. Okay, that's not how they were validated. That's not how they were intended to be used. And so those are the things that I have to guard against, particularly as assessments like that of keep getting scooped up and used by different people with different intentions. You know, I'd love to hear what Dr. Kelly has to say about that though.
Yeah, and you know, again, I think it depends on who's it for, who are the measures for. As I mentioned, you know, in terms of our clinical work, you know, what we're interested in is ready, willing, and able. You know, what's your level of motivation for change right now? What kind of self-efficacy and coping skills do you have? You know, what are you using? How are you using it? How's it affecting you? Looking at functional impairment, looking at pain, looking at shared needle use. These are the things I've measured at the micro level to look at change over time. So, you know, those are good. And again, because recovery, it's a process. And so stabilization is a process, starting with biological stabilization through psychological and social stabilization. And so measuring those in phased ways are important, I think, as well. So I think it really depends. I think we could agree on certain metrics, which would say we'd all nod and say, you know what, yeah, we should definitely include that in our clinical settings. And again, most patients who are coming in because of substance use want that measured. They like that measure. They like to see progress there. And then other indicators really expanding from there. Yeah, I've come up with a bunch of little metrics that I use myself that measure change over time in these areas that have been shown to predict longer term stability. And those can be swapped out and changed depending on patient goals.
John, I also don't want to underemphasize what you said before that I think we haven't emphasized, which is this other mechanism of a feedback loop with the clients themselves. We know it works for behavioral health symptoms of various kinds. The fact that that could also work for what we would call a flourishing tracking of some kind, but feeding them back to sort of overtime goals and how important and how therapeutic that can be to give that information back to the client. That's really remarkable. That's a landmark way of thinking about recovery feedback.
You know, here's one thing as well, just quickly from a clinical standpoint, is just getting people to come back. You know, the modal number of sessions in SUD treatment is one session. That's it. People leave. That's the modal number. How do we get people to come back to see us? And if you get people to come back, stay in treatment, stay engaged, that's a marker right there, a very important marker, just showing up. Tom McClellan used to say, you know, if they're showing up and they've got a negative urine, I know negative urine could be controversial here, but he would always say, you know, if they're showing up and they've got a negative urine, they're doing great. You know?
And so, I'll take just showing up.
Yeah, and showing up, yeah, the prime one, right? If they're showing up, wonderful, right? Because we know how hard it is for people to do anything, right? To get off the couch and get out the door, do something. So the fact that they actually show up on a regular basis is a strong marker of improvement. That would predict, just showing up would predict these other indices of other metrics.
Well, John, just thinking about time, are there last things that you want to make sure we get on the table, that you want to say to sum up, that you want to ask people before we call it a day?
No, I think this has been really great. I think the entire day, I speak for every word. We have our group chat in the background to do the air traffic control, and it's exceeded all of our expectations, you know, which were pretty high to begin with. But this has been a great discussion, both sessions. Really, thank you, Noel and Mark and Aaron and Jess for moderating. And yeah, what we'll do at this point is we're going to take the notes and the transcripts from today, try and provide that top level summary for everyone to set the stage for the next sessions that are on Monday. Kelvin is the leader of the first one of those sessions, so you will see him again, and he was here, so it won't just be my notes that you're relying on. But with that, yeah, I think if there's no other concluding remarks from anyone, we can get going a little bit early. And thank you again, everyone, for your time and investment today in the discussion and for the candor of what you put on the table. It's really, really appreciated.
Well, I
Thanks.
second that. Thank you to everybody. It's been a really rich conversation and so many important contributions and perspectives, and the passion and the commitment so evident.
Agreed. Thank you all so much. You were amazing. I know we had a lot of praise for the first panel, second panel. You all were also incredible. So thank you so much. And we look forward to seeing you all on Monday.
Yes,
Everyone's
please come
invited
back
back.
on Monday, because you know, speaking from someone who works in the division of neuroscience and behavior, these voices and these points and the individualization of recovery is a much more fruitful conversation than what's the right metric of, you know, connectivity or whatever to measure. So please do come back and please participate in the discussion on Monday. That's why we set the meeting up the way that we did. All right.
Thanks,
Class
everybody.
dismissed.
Bye,
See everyone
everyone.
on Monday.
Been a pleasure.
Thanks for
Thanks,
hosting.
everyone.
Thanks, Mark. Thanks, Aaron.